Welcome, everyone, to our webinar, 10 Years On, What Monitoring Shows About Attacks on Healthcare. Thank you for joining us. My name is Larissa Fast. I am professor of Humanitarian and Conflict Studies at the Humanitarian and Conflict Response Institute at the University of Manchester. I was also the principal investigator of the Researching the Impact of Attacks on Healthcare project, which was a 7-year project funded by the UK Foreign, Commonwealth and Development Office and wrapped up in March of this year at the end of that month. So together with colleagues, some of whom you'll hear from today, the RIAH Consortium researched and published about the immediate and longer-term impact of attacks on health, working with the organization Insecurity Insight to document these attacks, and with a series of academic partners to produce in-depth case studies of their impact. So you can find out more about the RIAH project and our publications via our website, and there should be a link going into the chat. So it's really in this capacity as the PI of RIAH that I'm joining my colleagues here to moderate what is a very sobering discussion, which is about the distressing state of attacks on healthcare 10 years after UN Security Council Resolution 2286. 2286 was a landmark related to the protection of healthcare in terms of both strengthening the norm and also in raising public awareness. It came on the heels of the bombing of the MSF hospital in Kunduz, Afghanistan by the US military, and after years of attacks in Syria and many other places around the world. Unfortunately, as we'll hear more about today, things have not improved. In fact, they've gotten worse. But I'll leave that detail to Christina in particular to speak about. So today marks the launch of one of, it's one of the final outputs of RIAH, which is this report, Still Under Attack, that we are launching today. It was produced by Insecurity Insight with support from RIAH and others, and focuses on 10 years of data about attacks on healthcare since the passage of 2286. So a little bit of housekeeping before I introduce our speakers. The aim is to do a recording, so this is actually being recorded, and we expect to make this available online. We'll have 2 sets of speaking, first by Christina and Len, who I'll introduce in a moment, followed by a short Q&A focused on clarifications from the report, and for Len, who unfortunately has to leave us a bit early. And then we'll proceed with the second half, and we'll be hearing from the Spanish Permanent Mission and from Médecins du Monde, from someone from Médecins du Monde. So without further ado, I'm going to introduce first Christina Wille, founder and director of Insecurity Insight. Insecurity Insight is an organization that examines threats facing people living and working in dangerous environments by using innovative data collection and analysis methods. Insecurity Insight was a key RIAH Consortium member and is also a member of and contributor to the Safeguarding Health in Conflict Coalition, with whom we also work closely. Christina is going to be speaking to the report and its findings. Following her is Len Rubenstein, who is a legal expert and with a specific focus on the protection of healthcare. He is emeritus professor at Johns Hopkins School of Public Health, the former executive director of Physicians for Human Rights, and also the founder of SHCC, the Safeguarding Health in Conflict Coalition. He's also the author of a book called Perilous Medicine, which you should read if you haven't already. So without further introductions, I turn it over to you, Christina.
Thank you, Larissa, and thank you everyone for being here and to discuss this important subject with us. So let me see that I get the presentation to start. Um, yeah, as Larissa said, what we are looking at is the 10 years since the passing of the UN Security Council Resolution 2286, which at the time was a hopeful event because it was done in reaction to what has become the recognition of regular attacks on healthcare. So this 10-year report was put together because we wanted to really see how have things developed. Everyone working in this space, I think, had a sense and a feeling that things had got worse. But is this just a feeling because there's more awareness, or is this actually a representation of reality? So we looked at all the information we had available, and yes, spoiler alert, you've already heard it, things have got worse, massively worse. And yes, there are limitations in the data. It is impossible to have continuously consistent monitoring in different countries in conflict over a long period of time. But despite these limitations, I have no doubt that the overall impression we are getting from looking at the data that this issue has not only not gotten better, not stayed the same, but has got considerably worse, is a representation of what is an unfortunate reality. And while the numbers are not precise, they are shocking in itself of just how many incidents in over 10 years and how many damaged health facilities and how many killed health workers we identified. And I'm sure this is an underreporting. Sometimes I hear people saying, oh, well, it is essentially something, a representation of what is happening in Gaza. And this is why I want to sort of start this conversation here by showing that, yes, the situation in Gaza was an exceptionally violent, destructive conflict that decimated the health system. But it is essentially only the peak of what is a widespread, common phenomenon in conflict and goes far beyond of what has been the concern. There's such high concern in Gaza. And that I think is really important to note because as those who may have looked at the latest SHCC reports, the total numbers in 25 are somewhat lower than in 24. But that in itself is a representation of how the violence in 25 in Gaza was reduced. In 13 countries, the recorded violence against healthcare increased in 25 compared to 24. And that to me is one of these key things that I think we have to reckon with. It has been used in some countries to an unbelievable extent, but it is a common practice in nearly all countries in conflict today. Now, healthcare in conflict, as I'm sure you all know, is protected for all, including for wounded soldiers. But I want to highlight here the extent to which it is also an issue of civilian protection. And this is particularly illustrated by the extent to which maternal health services have come under violent attack, with devastating consequences for communities for whom the arrival of a new child is usually a hopeful moment. And to see that being so frequently attacked is absolutely devastating for communities. And we will hear more about the particular context of sexual reproductive health from Léa from MDM later. And as we can see here, it has been Ukraine in particular, where the attacks on maternal health services have been extremely high, but they've equally been very common in Syria, Myanmar, and in grey here, it is also rising in many other countries at the moment. Another point that I think is really important for us all to reflect upon is who the health workers are who lose their life. And we can see here in yellow those who are employed as international humanitarian personnel intervening in conflict. In turquoise, those who are the subcontracted local partners to the international humanitarian system. And in red, the local health workers who really are suffering to incredible numbers this violence. Yes, this is also representing in a way of who are most of the health workers in conflict, but I think it is still important to look at it in this way because it underlines just how much this is an issue of grappling with the localization of overall support in conflict and how much it affects the frontline health workers and also how much they are at risk from experiencing not only death, but also arrest and other measures that occur so often in conflict. And then the final point about some of the key developments I want to highlight today is the extent to which the supply and the whole process behind healthcare has also become under attack. Healthcare needs health workers, it needs health facilities, but they can't function without drugs, with diagnostic equipment, and without patients actually being able to access health services. And it is exactly the supply and the access to healthcare that has just as much come under attack as the physical infrastructure of hospitals and the death of health workers. And that just underlines just how much the health system is under attack and how this really impacts the ability of people to receive life-saving care in conflict with devastating consequences for what has often been called the indirect deaths in a conflict. So one of the big questions I think most people have is, why on earth is this possible? And there are many different complex aspects to answering this questions. I just want to share a few things that sort of become very clear when we look at the data. And the first one is the realization that healthcare itself is extremely vulnerable. Healthcare needs the direct contact between the healthcare provider and the patient. That means direct contact. It means you can't put security measures between the patient and the healthcare provider. But the other aspect that makes healthcare so vulnerable is that healthcare is often delivered when people are in extreme stress situations. And this is also illustrated during public health emergencies. And it was very clear that during the COVID pandemic, violence against health was widespread globally, but it was also during the Ebola response in the DRC. And this is also something that is happening again just now as the 17th Ebola response, Ebola outbreak in the DRC has been declared. And already there have been 3 cases where tents set up to help suspected infected patients have been burned. So this is one of the elements that healthcare just is very vulnerable in such circumstances. But it is also vulnerable to the information ecosystem in which healthcare is delivered. And it is also a phenomenon that occurred in parallel to what we're discussing here over the last 10 years. That is that the extent to which populations globally, and in particular in conflict-affected areas, have access to new means of information has risen dramatically. And the figures we have is that it rose from 31% of the global population to close to 70%. And that is also changing the information environment, and the extent to which information can uncontrollably be shared has also undermined the trust in health systems, in particular during health responses. But as we will also discuss later, and I think as we will also sort of see in the particular aspects that Len will be discussing, it is also in the way the protection of healthcare is reinterpreted and reframed. And this is also partly driven by the information environment that has been developing over the past 10 years. But one of the key drivers of this violence are states. And that, I think, is something else for us all to really take into account. When we look at these, the vulnerability of the health system during outbreaks and pandemics, then it is largely community members, in particular in conflict-affected areas, who may come to violence against the health system. But the really high numbers to which we've seen this increase, this is states. And this is how states have means and intent of doing it. And one way of looking at it is how states have actually intervened in conflicts in a way that they affected healthcare. Some do it across border in other countries, others do it within their own territories. And this also is, I think, very important to consider when we're thinking about the vulnerability of the health system and who is responsible for protecting them. Because if it's their own states organizing the attacks on the health system, it becomes very difficult to do it through standard measures of where we're expecting states to find the solutions. But it is also clearly that, in particular, two armed forces have driven the violence across border in attacking the health system elsewhere, the Israeli Defense Forces and the armed forces of the Russian Federation, but they are not the only ones. There are many other forces that have done so at other times. And one very quick overview here in terms of the means, because during the COVID response, for example, we would see that someone would take a hot cup of coffee and attack a health worker with that. But that obviously has much less of a devastating impact than an aerial bombarding campaign. And this is what we can see here in this graph. In yellow at the bottom, these are all sorts of means in which healthcare has been attacked in conflict, whereas the red ones are the growing proportion to which explosive weapons, and these are normally the prerogative to a large extent of states, have been used in these violent attacks against the health system. And here, one other thing in top of yellow, in top of there, that highlights the extent to which we've seen now drones being part of the aerial strikes against the health sector. And this, I think, is important to bear in mind, because the changes and the increasing violence we've seen is also intrinsically linked to the overall developments in conflicts and the means available to states when conducting warfare. And all of this needs to be considered when we are thinking of addressing it to increase the safety of health services. So what has been done? I will not say very much here, because this would be discussions on their own, but I think it is very important to take note of it. This is a handbook on the security risk management for health services that I just want to show here as an example for the overall learning that has been widespread among frontline health workers in trying to find means of mitigating the violence in various ways, and with Syrian doctors sharing their experience with people in Myanmar and elsewhere. It is a collective learning of what can be done to mitigate the worst that has happened. But and this learning is ongoing. But one thing where there has been very, very little progress over the last 10 years is any legal accountability, given that these are against the laws of war. There have been 2 convictions, and some of them predating the even the UN Council resolution. And there are 2, to my knowledge, only 2 ongoing cases that are done through universal jurisdiction or as domestic courts in Ukraine. So this is an area where, given the scale of the violence, it is a very sobering level of progress in trying to also address the more criminal aspect of this violence. So to conclude, without wanting to go into many of these sort of recommendations now, but they are included in the report as also, we believe that there is a need to really reclaim the language around protection of healthcare, to emphasizing the responsibilities of all those who have the obligation to protect healthcare. This being the employers of health workers, but the armed forces who carry out their military campaigns during conflict. They all need to step up and make sure that the protection gets improved. And then there is the question of the legal cases, and where we hope that there can be more collaboration going forward with prosecutors who can take these issues forward. And we look to states to support effective humanitarian diplomacy to protect health workers in conflict. And with that, I will stop here and pass back to Larissa.
Great. Thank you so much, Christina, for that very sobering overview of what's been happening over the past 10 years. I'm going to turn now to Len to give us a sense of the legal context and what has changed. Over to you, Len.
Thanks, Larissa, and thanks to Insecurity Insight and RIAH for this very important report, and to Spain as well for its important leadership in protection of healthcare. What you've heard today from Christina is a crisis of protection of healthcare in conflict, but it is also a crisis in the law that is supposed to ensure that healthcare facilities can continue to serve patients and communities in wartime. It is a crisis of non-enforcement and lack of accountability, but also of attempts to erode the law's fundamental purposes. When states or non-state groups target a hospital, clinic, or an ambulance, they usually deny that they committed the act that they're accused of, try to shift blame for the incident, or make fanciful claims, for example, that the hospital was no longer functioning as a hospital. Such obvious contempt for obligations not to attack healthcare are usually and easily dismissed for the lies they are. In the war in Gaza, however, Israel has taken a different stance, that its attacks are justified. It says that because it claims that Hamas uses hospitals for military purposes and therefore may be attacked as legitimate targets. The Israeli Defense Forces has a website devoted to this claim. In a statement last month to the UN Security Council, Israel's representative went as far as to claim that 85% of the hospitals in Gaza are being used by Hamas for terrorist operations. It provided no evidence for this claim, and yet its narrative goes unchallenged. It is important for all of us to understand the basis for this justification and why it has to be rejected, and firmly so. Its position is based on a provision of international humanitarian law that says that a hospital loses protection if it is used to commit acts harmful to the enemy. These acts can include storing weapons, operating command centers, firing from the facility, among others. Such conduct is prohibited under the law. In only a handful of its attacks on hospitals, and Israel has attacked 34 of the 36 hospitals there, has Israel provided any evidence of Hamas use. In most cases, where it has provided some evidence, independent investigations have questioned it or found the evidence non-existent. So let's assume for the moment, though, that there is evidence that hasn't been disclosed of military use of hospitals by Hamas, and therefore they're at risk of loss of protection. But that's not the end of the matter. There remain very strict safeguards in the law to protect patients in the hospital, the medical staff, who of course have not lost their special protection, and the hospital's ability to continue to function. Israel largely ignores these requirements. And I want to briefly review 4 dimensions of these requirements so we're all clear on how serious a breach of the law this justification is. First, before taking any action, the potential attacker must issue a warning, and it's different from evacuation warnings to civilians to say leave an area because we're going to attack it. It's a warning that says unless the harmful acts cease and a reasonable time is given for response, it can't act. And that is, unless the misuser or alleged misuser does not respond or doesn't stop the misuse, nothing can happen. Only if there is no response can there be any action. Then other protections kick in. First, there has to be determination that the hospital is converted from a civilian object, which is completely protected, to a military object. But a military object has a very narrow definition. The object must make an effective contribution to military action and whose capture or destruction or neutralization offers a definite military advantage. Minor infractions do not turn a hospital into a military object. It's a very tough standard. Third is the rule of proportionality, which applies even if the hospital does become a military object. The rule is so significant that an intentional violation of the proportionality rule is a war crime. The rule says that an attack is prohibited if it is likely to cause loss of civilian life, injury to civilians, or damage to civilian objects, or a combination of them, that would be excessive in relation to the concrete and direct military advantage anticipated. So it requires a determination by the commander of the likely civilian harm and of the military advantage. Moreover, if once the attack begins, it has to be stopped if that calculus changes. And the rule applies not only to whether an attack can take place, but how it is conducted, including what weapons are used. Well, we have to consider the potential harms in a hospital attack, especially when explosive weapons, which are the most common form of attack, are used. Given the circumstances of patients in a hospital, many fragile, many needing life support, some undergoing surgery or giving birth, and the ongoing need to provide emergency and intensive care to patients in the community, the harms from an attack are almost always foreseeable and always severe. At the same time, the military advantage is often slight, often non-existent compared to the severe damage or destruction that will be inflicted. And it seems very clear that there are likely very few, if any, circumstances where bombing or shelling a hospital can meet the proportionality standard. As one court put it, trying to eliminate a sniper firing from a hospital would not justify blowing it up. Finally, an attacker must take all feasible precautions in the choice of means and methods of attack in order to minimize harm to civilians and civilian objects. That means, for example, in a ground incursion, special care must be taken to preserve essential functions and enable ongoing care so that water, electricity, and other essential requirements for functioning remain. In almost all cases of attacks in Gaza, Israel has done none of these things. If it cites precautions at all, which are rare, it is usually citing their evacuation or orders to evacuate patients, which itself is often a dangerous process, both medically and because of the lack of safety in transport. And yet what we need to recognize is that Israel is succeeding in creating a narrative that justifies hospital attacks. It is going largely unchallenged. And yet it is hard to imagine a position more dangerous and more undermining of the values and the law of protection than saying that hospital attacks are in fact justified. When critics push back on Israel, it doesn't disclose evidence claiming that it is based on intelligence that it can't share, and that means that it's extremely difficult to push back. At the same time, when critics do push back, the narrative changes to label the critics as complicit or silent in the view of Hamas's violations. All this has led states committed to the protection of healthcare to become somewhat paralyzed, as they don't want to get into the weeds of warning, proportionality, and precaution, and don't want to be seen as complicit with Hamas. And it's not difficult to imagine where this narrative goes. We've already seen the same pattern in Lebanon, and we can predict that for other military forces, the message is clear that all of a sudden, attacks which could never be justified in the past are now justifiable if you make the right claim. We can expect this to happen if the narrative is accepted. And that, of course, will lead to more suffering, more violence, all conducted with impunity. So what must we do to address this? We have to stand up. We have to overtly, strongly call this out. States, UN, and civil society must speak loudly against this perversion of the Geneva Conventions. And criminal investigations must be initiated to take on this very subject. This hasn't happened to date, but it's got to come out so that we can have a judicial resolution that reaffirms the sanctity of hospital protection and the rejection of bogus claims of legitimacy of these attacks. I'll stop there, and I'll happy to answer questions.
Great. Thanks so much, Len, for that overview of the legal protections and some about what we can do about it. So we have some time now for questions, specifically to Len, who has to leave us before we finish, but also questions perhaps of clarification about Christina's presentation. You are fine to either put questions in the Q&A box, which we will monitor, or else if you prefer to see it, to ask the question yourself, please raise your hand. I actually see a couple of questions already coming through, and let's go ahead and I'll share them. One around what can be done when the perpetrator is the country's own military dictatorship. Len, I'll maybe send that one to you. And Christina, if you have any thoughts on that, you're also welcome to answer.
Clearly, when the government is a perpetrator, it's hard to expect the calling on the government to take steps to stop the attacks. It's extremely difficult, but it has to be done. And we have to find ways to put pressures on these governments, whether a dictatorship or a democracy, it makes no difference. We have to find sources of pressure to make them stop. For example, one major source of pressure could be arms sales to fuel the conflict that other states can suspend. So that is leverage. There are also diplomatic forms of leverage. There are sanctions. There are all kinds of sources of leverage. And what we have to do is compel or put pressure on the governments that have the leverage to use it.
Okay, thanks, Len. Christina, any addition, or shall we go to the second question?
Yeah, maybe just to add very quickly that these cases where the governments are doing it to their own populations are clearly illustrating how difficult it is to expect that the issue is going to be solved by states alone. And this is, I think, where we really have to hope for support from civil society, as well as public prosecutors who might be using universal jurisdiction or other processes. As well as the means of providing the communication to affected populations. So I think we really need to see how other actors beyond states can also support in such circumstances.
Thanks, Christina. Our second question, have you noticed a change in the narratives used to frame, comment on, or justify attacks by the parties to conflict? And by NGOs, organizations, so either Israel or, say, the ICRC, both in the period before and after Gaza?
I guess I'll take that one. I would say before Gaza, there were occasional invocations of this narrative, but they were so rare, so infrequently, and so easily dismissed that they didn't stick. For example, in the war in Syria, the Assad regime claimed that it was attacking hospitals because they were being operated by terrorists, but no one believed it, and it was seriously and immediately refuted. And so it didn't stick. What's happening now is the narrative is open and beginning to be accepted. And that's where the change is, and frequent. It was not an issue that needed to be confronted in any serious way before Gaza, except in some exceptional cases, including in some prior wars in Gaza.
And maybe to add to that, so it's very hard to say that there of what sort of systematic change there has been, because I think for exactly the reasons Len said, there was much less awareness, so there was no sort of systematic monitoring of how the shift has occurred. But it's pretty clear that it has happened. And just to give one example, we have just looked at the conversations around what we call the sequential strikes on first responders in Lebanon. They're quite often called double tap strikes, but I believe this is sort of minimizing something that is a very serious way of attacking first responders who respond to the to people needing medical attention after a first strike. So we've looked at the conversations that go on in Lebanon and in Israel in response to these same events. And it is quite striking that the conversations are very different. And I'm sure this has always been the case in conflict. But the while within Lebanon, there always are requests of why is there not better support for the first responders to safely go to do their work? On Israeli accounts, there are not many accounts, but some accounts that systematically put out the allegations that the emblem has been misused and therefore implying that the attack was justified. And that is just something we're seeing more and more, that following a strike on a hospital on first responders, that are people out there on social media from particular accounts that very systematically allege that, as Len pointed out, allege that the protection has been lost. There's never any evidence for it provided in these social media narratives. But I think this is the key thing we need to grapple with, that there is these very strong attempt to shift the narrative. And I believe it is relatively new that this is now happening systematically after such strikes.
Thanks both for those, disturbing, especially disturbing trends. There's another question about, it's a two-part question, but I think let's leave the second part until toward the end. But the first part of the question is regarding, and I think I know the answer to this, but I'll let you both jump in. Are there any ongoing investigations of potential violations of IHL for the hospitals that have been attacked? And Len, you mentioned in particular 34 of the 36 hospitals in Gaza.
I'm not aware of any. We don't know exactly what investigations the International Criminal Court is undertaking since it issued the indictments now a long time ago. So we just don't know.
Okay. All right. Any other questions for Len in particular? Or also questions of clarification on the report? If not, let's go ahead to our second set of panelists. So I'd like to first go to and thank Ms. María Ibáñez Beltrán, who is the advisor for humanitarian affairs at the Permanent Mission of Spain to the United Nations and other international organizations in Geneva. So thank you for coming, and I believe you're going to speak about the Spanish position and support to the agenda. And then following María is Léa Gauthier, who is in humanitarian advocacy at Médecins du Monde, and she will speak about how attacks on health impact on maternal health services. So I will turn first to María. The floor is yours.
Thank you, Larissa. First of all, I want to thank the invitation. It is a pleasure for us at the Spanish Permanent Mission in Geneva to participate in this webinar, marking the launch of this report done by Insecurity Insight and all the other partners, and presenting the findings of a decade of analysis on attacks against healthcare. And also, as mentioned during the discussion, coinciding with the 10th anniversary of the United Nations Security Council Resolution 2286 on the protection of healthcare. We welcome this opportunity to reaffirm Spain's strong commitment to this agenda, to share our efforts, and to encourage all states to translate political commitments into concrete action. And we also want to express our appreciation for the work of organizations such as Insecurity Insight, whose rigorous data collection and analysis is crucial to improving understanding and to inform policy, and also to strengthen the protection of healthcare in armed conflicts. So Resolution 2286 was, as mentioned, a historic milestone in the defense of international humanitarian law. And it reaffirmed a very simple core principle that medical personnel, facilities, patients, and transport must never become targets. And Spain was very proud, and is still very proud, to play a leading role in advancing this resolution, alongside with a broad coalition of states and other partners. And however, and as it's been clearly shown in the remarks presented by all the speakers so far, 10 years later, implementation remains insufficient. Attacks against healthcare continue at alarming levels, and as shown by the report and by the remarks done by Christina and Len. And also there is new patterns of violence, including the use of low-cost drones and other technologies that further increase the risk for civilians. And at the same time, as also mentioned by Len, the erosion of public discourse, which sometimes appears to justify this type of attacks, poses an additional challenge that is very, very dangerous. This is why we consider that anniversaries such as these must not just be moments for commemoration, but moments for a renewed commitment and moments for concrete action. And that's why Spain has been engaging recently, also because of the commemoration and the 10-year anniversary, but in general, over the last 10 years, we've been engaging very actively in this agenda. We've been condemning unequivocally any attacks against medical personnel and facilities, regardless of the context, regardless of the perpetrators, and we consistently call to a full compliance of international humanitarian law. And in general, we can summarize our main actions in three main lines. First, we've been trying to strengthen compliance with international humanitarian law, including through its integration in military doctrine, training, and operations. This is a priority that has been reflected in our 2023-2026 humanitarian diplomacy strategy that will continue to be reflected in the upcoming strategy that we will launch next year, and also in our work in multilateral initiatives such as the ICRC Global Initiative to Galvanize Political Commitment in International Humanitarian Law, where we co-chair the work stream on protection of hospitals. And we're working currently to develop a set of concrete recommendations that ensure protection and that avoid precisely all those situations where protection is lost or states try to get rid of that protection, as Len mentioned. And the recommendations will be presented in a high-level conference in Jordan later this year in December. The second line of work would be advancing concrete protective measures and reinforcing accountability. The fight against impunity is a priority for us. We support independent investigations and accountability mechanisms, and we try to work with international bodies. We've been largely supporting the work of the International Criminal Court and other UN monitoring mechanisms. And last but not least, we consider it's of utmost importance to improve the availability and the quality of data. Effective prevention and accountability depend on reliable information. And in this context, the work of Insecurity Insight is particularly valuable. In a sense, reliable data helps transform individual incidents into evidence into policy, and policy into protection on the ground. And we try to encourage all states to support these type of initiatives, to invest in robust data systems and information sharing. There's key tools to implement Resolution 2286. And just to conclude, let me conclude by reiterating Spain's strong commitment to the agenda, and by conveying also a very simple message. Even in war, there are limits, and the protection of healthcare is above all a matter of humanity, as it is described in the report. In times of war, few rules are as essential as those that ensure that those who heal, those who stand ready, those who save lives can carry out their work without becoming targets. So as in Spain, we stand ready to continue working on this agenda with all partners and to advance all possible progress in this direction. And we encourage all stakeholders to join in reinforcing our efforts. And thank you very much for the invitation.
Thanks so much, Maria, for that strong statement in support of the agenda and for your continued work on this topic. I'm going to turn now to Léa from Médecins du Monde. So over to you, Léa.
Thank you, Larissa. Thank you all, and thank you for the invitation to contribute to this important discussion. And thanks also to Insecurity Insight, the ACHCC, and the RIAH project for a decade of rigorous and very important documentation. So this report launched today shows a really stark reality. We've been discussing it. Attacks on healthcare have tripled in recent years, and sexual and reproductive health services are among the most severely attacked and affected. So I want to bring these findings to life by sharing what Médecins du Monde, Doctors of the World, sees every day in the field where we work. We see the immediate effects but also the long-lasting, the reverberating impacts of attacks against healthcare in Syria, in Yemen, in Ukraine, in the DRC, the Sahel, Nigeria, Palestine, etc. Let me maybe start with one example. When a telemedicine center in Novorossiysk near Kherson in Ukraine was destroyed overnight in September 2024, 3,800 people lost all access to healthcare instantly. It took us months to rebuild the service elsewhere and to replace all the equipment. And during that time, health issues accumulated and worsened because they went untreated. This is what an attack on healthcare looks like in practice. It's a sudden collapse of access followed by months of preventable suffering. And here the report's data is clear. Sexual and reproductive health are disproportionately harmed. And this is what I want to focus on today for a few minutes. The report that Christina mentioned highlights more than 400 attacks directly affecting maternal health services. And for us at MDM, these numbers translate into very real consequences. It means pregnancies that become life-threatening, newborns who do not survive their first days of life, untreated infections that lead to problematic consequences, including infertility, and women giving birth in conditions that violate every standard of dignity and safety. So yeah, this is the human face of all this data that we're discussing today. In Gaza, where we've been working for more than 25 years, we have documented how recent attacks on healthcare destroy sexual and maternal health. So since late 2023, MDM teams have provided nearly 1 million consultations in 7 primary healthcare centers all across Gaza. And our colleagues there have been delivering care and services in almost impossible conditions. All of our teams were displaced, sometimes multiple times. Our Gaza office was bombed and occupied in February 2024. We had to evacuate clinics and staff from Rafah in May 2024, and one of our clinics was actually damaged in a bombing in September 2025. These are not isolated incidents, and they reflect the pattern that is described in the reports. But despite all of this, our teams managed to document and analyze the data on sexual and maternal health from May 24 to August 25. And the findings are alarming. I want to share a few of them, three main impacts. The first one is that we saw a massive rise in genital infections that are linked to displacement and infrastructure collapse. Our data show that 84% of women with genital infections had been displaced more than once. So the destruction of the water, the sanitation systems has made menstrual hygiene almost impossible. And women started increasingly to rely on unsafe coping mechanisms, such as using dirty clothes or else to manage their menstruation. And these infections are not minor. If they go untreated, they can lead to infertility, chronic pelvic pain, etc. So it's quite serious. And this is exactly what the report warns about when it talks about quiet disruptions, like the collapse of water system or the blockade of hygiene supplies. These have profound long-term impacts on health system and women's bodies. The second thing that we saw most was the collapse of prenatal care and the rise in pregnancies complications. So before the war, Gaza had one of the lowest maternal mortality in the region, actually, and women typically received 67 antenatal care consultations, so it was quite good. But in our 2025 study, we saw that only 18% of pregnant women actually received comprehensive prenatal care, and the consequences are catastrophic. 85% of the pregnancies that we see now present at least one complications. Before the war, it was only 10%. We see acute malnutrition in 1 in 3 pregnant women. And yes, this is still the case today with the ceasefire ongoing, and infections in more than half of them. So this can lead to hemorrhage, sepsis, increased maternal mortality, preterm birth, and has also consequences on children. Among the 100 pregnant women that we saw in our study, more than 20% of their newborns were affected, with nearly 10 of them dying in their first days of life. And here I wanted to share the words of my colleague, Dr. Isra, who's the medical advisor for MDM in Gaza. And she told us, pregnant women are giving birth in overcrowded shelters, makeshift tents, or on the road while fleeing airstrikes, often without medical assistance, pain relief, or sanitation. So this is to give an example or an idea of what women are going through in when health systems are attacked. The third point that we saw is that really humanitarian access determines life or death. Our data show a very striking pattern. So during the January to March 2025 ceasefire, when aid was actually facilitated, genital infections in our clinic dropped by 50%, and prenatal consultations increased. And when aid was blocked again in March 2025, the number of patients collapsed, not because needs decreased, but because women could no longer reach care. And this actually perfectly illustrates one of the report's key findings. Hindering access to care is a fundamental denial of the right to health. Because attacks on healthcare are not only bombs, they are also blockades, restrictions of medical supplies, evacuation of clinics, and the criminalization of healthcare. And all of these are well documented in the report as growing global trends. And this is not limited to Gaza. In Yemen and in Nigeria, where we work to provide nutrition services to women and children, some areas are completely unreachable for international and sometimes even for local organizations because of conflict or because they are controlled by armed groups that are designated as terrorists. Entire communities then are left without access to essential maternal and child health services. In Lebanon has been mentioned a couple of times already in this discussion. But we had medical staff told us that how they started to adopt mitigation measures to protect themselves, but that also directly reduced the effectiveness of emergency response. One hospital director explained that his ambulance team now delays response for up to several hours after an attack to avoid the risk of second or third strikes or double tapping, as we've heard. And some emergency services also reported being blocked from entering certain towns or certain villages due to fears that they would attract further attacks, forcing them to take longer routes. It's almost certain that all of these delays reduce the survival chances of those who were injured. I just want to say a word about the psychological dimension of these attacks, because more than 80% of the women and girls that we saw in our clinics in Gaza report psychological distress, hypervigilance, fear of death, insomnia, despair, etc. And another report actually from MDM on the West Bank shows how the occupation there dismantled the very conditions needed for psychological healing: safety, stability, community, and access to mental health care. And those trends, we also see them in Ukraine, in Nigeria, in Yemen, when mental health needs are rising, soaring, while the conditions required for psychological healing are systematically dismantled. And for us, this is not secondary effect. They are really part of the harm that must be documented, analyzed, and addressed. So what does this mean for the humanitarian community and for the community as a whole? The report we're discussing today calls for stronger accountability, better data, renewed commitment to protecting healthcare. And as Médecins du Monde, Doctors of the World, we fully support all of these recommendations. I just want to underscore one essential point. Humanitarian access must be guaranteed, including access to reproductive health kits, menstrual hygiene materials, and essential medicine. At a time of hyper prioritization and shrinking budgets, we must really collectively ensure that sexual and reproductive healthcare does not fall off the agenda. States, particularly those championing feminist foreign policies, and here I want to acknowledge and thank the Spanish leadership on the question, have a really specific role and responsibility to take to fund and defend sexual and reproductive healthcare in conflict settings, and to use political influence to ensure these services are recognized as essential life-saving care and not as secondary. This includes contraception, safe abortion, prenatal care, etc. They are not optional services, they are obligation under IHL and human rights law. So the report shows us the scale of the problem. I think MDM's experience shows us the human costs. And as my colleague Dr. Isra told us, the war is not only destroying infrastructure and lives, it is also destroying the future womb by womb. Thank you.
Thanks, Léa, for that very clear reminder of the human and catastrophic consequences of armed conflict and also attacks on healthcare. I was struck by your comments around the adaptations and delays that result because of attacks on healthcare, the fear that modifies patient behavior, that modifies the way that healthcare responders can and do respond. One of the things that we also found was the willingness to remain in the profession. Targeted attacks on healthcare also disrupt the continuity of sort of generational care for well into the future. Okay, thanks. We have a number of questions already in place. I'm going to perhaps go to the first one, which is around systems to either, and this one's, I think, especially for Christina, about systems that might be in place to either track or predict new weapons trends. And if you want to say a little bit about that, and then we'll turn to the other two questions. I encourage everyone else to put your questions in the Q&A, and we'll keep that open. So, Christina, over to you first.
Yeah, no, thank you for those questions. Maybe for the first, why does it matter what weapon systems are used? I think there's two reasons why this is really important information. It explains the extent to which an actor can cause harm, and it also has important implications for how these weapons can be used or are used in relation to the laws of war. And that's why I think it is actually very important to look at what weapon systems are being used. And one of the new ones that have really been identified quite widely are the use of drones. And just to sort of illustrate why I believe this is really very important to consider is not only the way it shifts the vulnerability, because these weapon systems can arrive at all places from a long distance, but there's also important implications in there if we're thinking of what approaches need to be used to limit the harm. And one of the key elements here is that many of these weapon systems are being developed by private companies, and they're not directly bound by IHL. So there are many issues around it where I think we really need to think very profoundly as a community. How do we address these technological developments to ensure that they also take into consideration all these obligations that states have when it is increasingly a private sector developing these things. So yeah, I think it is very important to track these things and then to think and ask the questions, well, what does it tell us? What do we need to do now?
Thanks, Christina. We have another question that sort of builds on that. I'm going to shorten it somewhat. It's really around sort of the notion of what can we do in the immediate to minimize casualties from attacks on healthcare, to minimize harm. Arms sales, even your legal accountability take time. So what can be done in the immediate to minimize the suffering that results from attacks on healthcare? And this I open the floor to anyone who wants to answer.
I can make a start, but
Go
I'm
ahead.
sure others might want to contribute to that. There are many small things that can be done on the ground, but this also requires that those who fund health services in conflict provide the necessary means that enable healthcare providing organizations to put certain measures in place, be this moving facilities underground or in protected spaces, moving the access to facilities further apart, providing a training to people, allowing people to sleep in safe places. So there's many small things that can be done to make it a little safer. This is something that the healthcare providers need to do, but they need to be enabled by those who fund it. And that's why I think it's also important that we pass on this message to diaspora communities, to states funding healthcare in conflict, that they also need to think of their healthcare personnel and the systems, and not only the particular healthcare programs that are to be delivered.
Okay. Léa, what kinds of things is MDM doing around this, if you want to jump in here?
So we do have very strict security risk management policies, and we work on them with our partners, sometimes ministries of health, etc., to make sure that there is a good understanding of the risks and a good assessment and mitigation of the risks. Of course, that also means that sometimes we need to delay or postpone activities. I'm thinking about mental clinics or vaccination campaigns, for instance. If the security conditions are not there, we might not conduct the activity, which means further delays in terms of access to healthcare for communities who might depend on them. This is a few examples of what we do to minimize the risks of attacks.
Yeah, thanks for that. It's an imperfect answer, I think, to that question, everyone, but I guess it's part of what we all struggle with, is how to minimize that suffering that results. So the next question we have is around, and I think, Léa, this one is probably also for you, the 2025 SHCC report. It refers to the mental health issues that healthcare workers, medical staff experience during conflict. Is this something that your teams also experience? It's something we certainly documented in the RIAH research.
Yes, thank you very much for this very important question as well. We do experience it, and our teams and colleagues do experience mental health issues while navigating professional risks in conflicts. I have to also underline that in many cases, our colleagues working to provide healthcare are also themselves living a situation of conflict. It was very clear in Gaza. I mentioned that many of my colleagues were actually displaced several times. They were providing care in MDM's clinics during the day and returning to tents, to cars, to garages at night because they had to flee their own homes. For this, we have implemented a very specific duty of care for staff. So we provide psychosocial service to our teams affected by crisis or by conflicts. Sometimes within the team, sometimes with external professional help. It depends. We've also had feedback that in some cases, actually continuing to provide healthcare in conflict was also giving our colleagues a sense of purpose, of help, and was actually helping them go through the difficulties of daily lives, not minimizing it, but there's a feedback that we've had as well. And I also want to underline that as humanitarian organization, we take this issue of mental health more and more seriously. And now we've also tried to organize with other humanitarian organizations to make sure that we're able to provide psychosocial services to all of our colleagues, sometimes by mutualizing resources to make sure that we have a pool of psychologists, for instance, that are available for different organizations and staff, etc. It's the case in the Sahel region. We're also starting to implement it in Yemen, etc. And it's the case in the Middle East. So yes, we do take this very seriously.
Thanks for that. I see, Anna, you have a question, so over to you.
Thanks, Larissa, and I'm sorry because I don't know why I couldn't post that on the Q&A box. But I wanted to ask the three of you, María, Christina, and Léa, a little bit about what to expect for the next 10 years. If you had one or two suggestions of what we can do as part of a civil society that advocates for stopping attacks, who should we be bothering? Whose door should we be knocking at to push for change, in your opinion? And of course, it can vary between them. Thank you.
Anyone want to go first?
Well,
Christina,
I
go ahead.
Start first that I think this is such an important issue that I think a general public has no difficulties understanding in its urgency. And I think we need to make sure it becomes more of a publicly acknowledged and addressed issue. And I would particularly hope that parliamentarians and public opinion makers in various societies really start to ask for this, because I do believe there would be general public support. And maybe one of the difficulties we had over the last 10 years was that it was a relatively technical, legal, expert level issue. And so, yeah, I think we need to take it wider and get broad public support to make sure this sort of violence stops.
And just to, if I may add in on that, I think one of the other pieces of that is to engage the professions, the professional associations of doctors, of nurses. There was someone who posted a report from the Royal College of Nurses, I believe, so also sort of making that link to the medical professionals in our own countries, I think, and engaging them as well is another avenue that we can perhaps work at as we think about public engagement. So that would be my 2 cents that I'll just jump in after you, Christina, but over to Léa and then María.
Thanks, Larissa. I can continue. I think what Christina and Len before mentioned about narratives is going to be really key in the next few years. How, as medical professionals, we're able to reclaim the narrative that that protecting healthcare, no matter what, no matter when, including in conflict, goes back to our shared humanity. And I think that María mentioned it earlier, and it's really key for all of us to engage different stakeholders on reclaiming this narrative. I think there will also be a key issue on exemplarity from states and on calling out states that do not respect IHL and do not respect the protection of healthcare in conflict. This is a long road and it's complicated. We all understand how and why, yet it's clearly going to be key if we want to reverse the warring trends of attacks.
Thanks, Léa. María, any thoughts to add?
Thank you. I think I just want to reinstate the same remarks then by the rest of the participants. We also consider the narratives as being the most troubling part, or one of the most troubling parts in terms of how these issues going to develop in the next few years. I think it's very important to always call out on these violations and to avoid the normalization of certain discourses that are trying to justify certain behaviors that under no circumstances should be tolerated. So as from the Ministry of Foreign Affairs and from the representations and from the diplomatic standpoint, we can convey these messages in forums, and we can have discussions and fight for avoiding the specific changes in terms of how the main resolutions and recommendations come out of like forums like the one I mentioned in the ICRC. But I think for academia and other civil society organizations, it's important to convey this message also to the wider public, because as Christina said, it's a topic that obviously conveys wide public support, and I think there would be very little opposition to pushing for this agenda in the next few years.
Thanks for that. I mean, it strikes me in this way, 2286 is a welcome opportunity to put a spotlight on this issue for the entire year of 2026. And that's something, there will be other events, other, reports coming out as the year progresses. And I hope that these can be used then to maintain attention on this crucial issue. I don't see any more questions in the Q&A. I'm wondering if there's any other participants, attendees who would like to ask anything. But otherwise, I'm going to turn to our panelists for a final remark if we don't get any other questions. So, yeah, I don't see anything coming. So why don't I might go in, I was going to say in reverse order to see María, then Léa, then Christina, if you have any last comments or remarks that you would like to make before we close.
From my side, just want to thank you again for the invitation and also for your very valuable work with the report. We have received the report. We are going to really go through it, and it will definitely be one of the main sources that we'll use to inform our policy and future actions in this agenda. So thank you so much.
Thank you. Léa.
Thank you very much also for the opportunity to illustrate some of the report's aspects with key experience from MDM in the field. I hope I was able to share how disproportionately attacks affects mother, girls, sexual and reproductive health. And I want to really underline that these effects should not be overlooked, and that they should keep being a priority in the upcoming discussions. Thank you.
Thanks, Léa. And Christina.
Well, my thanks really go to the other panelists for being here, for sharing your insights into this, for you, Larissa, moderating this, for Anna, for all the help in organizing it, and most of all for everyone who came today and for all your commitment on this issue. And I very much hope that we have opportunities to collaborate closely in the future to see what we can do with many pathways to try to address this very serious issue that causes so much harm to so many people.
Thanks, Christina, and thanks. I'll add my appreciation to the panel for your time, also to Len, who unfortunately had to leave us, and to all of you who joined us. Thanks very much. We will, I presume, probably have this webinar. We'll release it on the HCRI website if you'd like to come back and see it afterwards. And obviously the links to the report and other resources are already in the webinar chat. Thanks very much for joining us.